Hello everyone. The title of my presentation is Role of Amniotic Membrane Transplantation in Treating Acute Ocular Manifestations in Stevens-Johnson Syndrome and its Long-Term Impact. There is a prevalent thought among clinicians that once a patient develops Stevens-Johnson Syndrome, his or her fate is largely painful and nothing much can be done to change the disease course. It's natural to have this thought considering the long-term outcomes that we come across in our clinical practice in terms of severe dry eye, limbal stem cell deficiency, and lid viper keratopathy. This presentation will help us change our mind regarding the disease. These are the questions that we would like to address by the end of this presentation. I would like to take you through a case of an 18-year-old female who presented to us with complaints of sudden onset rashes all over the body, photophobia, redness, pain, and diminution of vision in both the eyes for 10 days. She was a known case of seizure disorder on various anti-epileptic medications, and lamotrigine was added recently 6 weeks ago. The patient developed sudden onset rashes, watering from the eyes, and painful swallowing for the last 10 days. She was diagnosed as a case of Stevens-Johnson syndrome and was started on pulse dose of steroids, antidepressants, and other supportive care. On systemic examination, she had rashes all over the body. There were multiple flaccid bullae and purpuric macules with sheet-like epidermal detachment, along with multiple mucosal site involvement, and a diagnosis of Stevens-Johnson syndrome was confirmed. On ocular examination, her right eye visual acuity was 3/60, and in the left eye it was hand motions with accurate projection of rays. The facial features suggestive of scabs all over the face. In both the eyes, there were scabs over the lids with de-epithelialized lid margin, crusting at the lid margin with matting of eyelashes. There was mechanical eversion of the lower lid with temporal ankyloblephron in both the eyes. There were bilateral diffuse bulbar conjunctival congestion along with presence of true membranes over the palpebral conjunctiva. There were desquamated sheets of conjunctival epithelium attached to the lid margin and overhanging the cornea. There were nasal and temporal symblepharon in both the eyes. On examination of the cornea, right eye showed clear cornea with punctate erosions, whereas left eye showed total corneal epithelial defect with diffuse corneal stromal edema precluding anterior segment examination. This is the clinical picture of the right eye, wherein we can see that the red line shows the grey line of the lid margin. The posterior lid margin has been shown in green, and the structure behind the posterior lid margin is desquamated conjunctival and corneal epithelial cells attached to the posterior lid margin. The symblepharon has been shown in yellow. So, a final diagnosis of Stevens-Johnson syndrome with bilateral grade 3 ocular involvement was made, and a plan of bilateral membrane peeling with amniotic membrane grafting was made. Here is a short video on how to perform amniotic membrane transplantation in Stevens-Johnson syndrome. Following thorough wash of the ocular surface, the necrosed conjunctival membranes are peeled off. The symblephrons are released and the fornices are swept to break any adhesions. Following this, a speculum is inserted to facilitate amniotic membrane graft spread over the ocular surface. Once the amniotic membrane graft is placed over the ocular surface, it is spread evenly over the ocular surface. It is also tucked into the fornices and is fixed at the place with the help of a ring which is made out of an infant feeding tube. This ring not only spreads the amniotic membrane over the cornea and surrounding conjunctiva, but also stretches the amniotic membrane to the fornices, and specifically to the superior temporal fornices where opens the lacrimal gland ductules. The redundant amniotic membrane is reflected onto the lid margin. These lid margins are bare lid margins which are now covered with amniotic membrane graft. Post-operatively, the patient was started on topical antibiotics, lubricants, cycloplegic and steroids. These are post-operative pictures at 1 week wherein we can see that the patient is opening her eyes comfortably. Now coming to the questions that we had raised in the beginning, can we prevent corneal vascularization or conjunctivalization? Stevens-Johnson syndrome, being severe inflammatory condition, has the potential to damage the limbal stem cells. However, if amniotic membrane grafting is done at the earliest, the effect of inflammation decreases and this mitigates the damage to the limbal stem cells. These are the clinical picture at 1 year wherein we can see that our patient did not develop corneal vascularization or conjunctivalization. Coming to the second question, can we prevent lid viper keratopathy? Severe inflammation in Stevens-Johnson syndrome causes exuberant deposition of keratin at the lid margin, which subsequently causes lid viper keratopathy. These are the clinical pictures of our patient wherein we can see that there is conjunctival scarring, however there are no lid viper keratopathy and no lid margin keratinization. Same is true for the lower lids as well. Now coming to the third question, can we prevent severe dry eye? These are the serial photographs of the right eye superiotemporal fornix under cobalt blue filter. Upon application of fluorescent dye, we can see that a dot-like structure is increasing in size over a period of time. This shows active tear secretion from the lacrimal ductules lying at the superiotemporal fornix. These are the results at 1 year. Similarly, in the left eye, we can again see active tear secretion from the superiotemporal fornix. So the take-home message here is that one should have a lower threshold to perform amniotic membrane transplantation in patients with Stevens-Johnson syndrome with significant ocular involvement. One should also understand that acute inflammation, if controlled well in time and well in advance, can actually change the disease course. Thank you.